Hi, good afternoon, everyone. So, we all know lung cancer is a big problem. It's the third most common cancer in the UK and one of the biggest killers as well. We also know that if you can diagnose lung cancer early, your chances of getting a better outcome are vastly improved. We know this in the NHS, and there is a national optimised lung cancer pathway that was introduced in 2017 by NHS England. This optimised lung cancer pathway aims to get people from the time of being flagged up as having potential cancer to getting their cancer treatment within 28 days. However, relevant to us in radiology, prior to that, there is a very fast turnaround time that is supposedly optimal, and that's 3 days, used to be 5 days, for us to get the chest X-ray and the CT done if there is a suspicion for lung cancer. However, as you can imagine in the NHS, this isn't always possible, and there are huge variabilities in how this service is delivered. So in the Southwest London, within our AI group, we wanted to know whether an AI-enhanced pathway could improve the time that patients get their CTs if they're flagged up with a suspicious finding on their chest X-ray, whether or not we can do this within the 3-day turnaround time we want, and whether or not we're getting time to the authorized radiologist reports any faster with this triage system. We also want to know that if we implement AI, how do our staff feel about it? Is this going to be acceptable to them? Is this something they like to use? And will they continue to want to use it? So we decided to implement an AI solution in one of the trusts within the Southwest London AI group. That trust was Epsom and St Helier's Hospital, and we went live at December last year. You may be asking, where the hell is St Helier's and Epsom Hospital? Well, this is where we are in central London right now. Epsom and St Helier Hospital are two hospitals within the same trust based in Surrey in the southwest, and they cover a catchment population of about 500,000 people. The radiology department has about 200 members of staff, of which 30 would report chest X-rays. In a prior audit in 2021, it was found that only 2/3 of patients were getting their CT scan within the, at that time, recommended 5-day timeframe, which clearly isn't good enough. So we wanted to improve that, and that's why this AI solution was thought about for this particular pathway in the beginning. So let me talk you through what the actual patient flow looks like without AI and how we thought AI could be implemented. So usually what would happen is if you are a patient and you have a cough or you cough up blood or your GP thinks maybe this could be lung cancer, they send you to the hospital and you get your chest X-ray taken within the outpatient department. You would then go home, wait for someone to call you, and if the chest X-ray was reported as abnormal within a 2-day time period, you would be then called by a secretary in our radiology department and asked to come back for a CT chest, which would happen sometime in the next 3 days. And then that CT chest would happen, and then you would get the report in the next 48 hours, and then based on that, maybe get referred on to specialist care. However, what we wanted to do was implement the AI solution at the time the patient was in the radiology department. So that means when the chest X-ray is taken, the patient would wait in the department. The AI, if they thought there was something there, would flag it up, and the radiographer would call the duty radiologist to report it there and then. And if that was agreed that there was something suspicious, the patient would then be offered a CT at that same time, either the same day or to come in the next day, depending when their chest X-ray was taken. And then hopefully, if you have the CT the same day, that report would then be done within 2 days, and therefore shortening that whole turnaround time to within 2 days or 3 days, rather than the usual 5 or 7 days before. So that's how we wanted to implement AI. Through a lot of discussions with the local radiologists and also the integration leads and the IT system, the AI system that was chosen eventually was the Annalise Enterprise Chest X-ray product. As you can see here with the diagram, what happens is you have a chest X-ray that gets sent to PACS or to the local workstation that the radiographers are looking at in the X-ray room. A little icon pops up with the AI overlay, which says what the AI thinks is there, and you can click on the different pathologies and it will show up what it thinks is present. The Annalise enterprise chest X-ray system can actually detect over 120 different chest pathologies. But because we were specifically interested in lung cancer, we didn't want a whole 120 different things being flagged up, which might confuse the radiographers and also the local radiologists as well as to what to refer for same-day CT. So in consultation with the whole radiology department, the top 14 most critical findings were selected, and you can see what those 14 were on the side there. So these were turned on, as it were, and if any of those 14 were flagged by the AI, then the radiographers would call the duty radiologist to then report the chest X-ray and potentially refer on to CT quickly. So let me show you a little bit about our preliminary analyses. What we wanted to do was to go live with this AI really early on in October last year, but we actually did eventually go live on the 19th of December 2022, and we want to run this for 6 months until June. So we're actually still evaluating. It's still live. We're still collecting data. So what I'm showing you is just the early findings right now. We wanted to compare it to what things were like in Epsom St. Helier before the AI was there, so without any triage and without any referral to CT. However, in between thinking of when we wanted to start the AI, which was in October, to actually starting it, we had a slight delay of 2 months. And during that time, we said to the radiographers, whilst we're waiting for the AI to go live, why don't you do the triage? So we'll have a human triage based on the radiographers looking and seeing if there's anything obvious to them. So we'll compare before any AI, with radiographer triage, and then once we had the AI go live. So let me show you the results of those 3 different time periods. Here you can see a table of the 3 time periods and the times, the dates, and how many chest X-ray were referred during those times. If you look at the percentage or proportion of chest X-rays that were flagged by the radiologist in their report as suspicious of lung cancer, you can see that that has remained steady at 2% during each of the 3 time periods. So even with AI, even with flagging up, we're not suddenly calling loads of things lung cancer. That seems to be pretty steady, which is good to know. However, you can see that the percentage of patients getting CT follow-up for the same day has increased from 4% to 32%. Those getting CT within the same 3 days of having a suspicious chest X-ray has gone from 42% to 62%. And you can see that actually any CT for any suspicious chest X-ray of lung cancer within 5 days has also gone up as well. Now, when you look at the very bottom row, it's telling you how many patients had a CT within that same month who had a suspicious chest X-ray. And that looks like it's gone down a little bit from 97% to 91%, but I would just like to highlight again that this is still an ongoing analysis, and during the 4 months where we started the go live, a lot of things unrelated to the AI have happened, namely ambulance strikes, nursing strikes, junior doctor strikes. So that has somewhat implemented and had an impact on who had a CT in the timely manner. But I hope that by the 6 months we can reanalyze this and that will be better. If we look at time to actually getting the authorized reports for the chest X-ray and the CT, you can see that with the AI triage, that turnaround time has also reduced for all factors. Time from the average chest X-ray exam to the CT exam in days has gone from almost 5 days to 2.5 days. And also you can see that reporting times have also reduced for each of the different exams as well. So it has definitely helped in turning around how efficiently we're getting reports and how many patients are getting a more expedited CT scan. Let me show you some real-world examples. So one that's quite interesting for me was this patient, 59-year-old male, sent by GP for query lung cancer. So a few things. Number one, you can see the chest X-ray has been done in 2 parts because they weren't able to get the full lung and the hemidiaphragms on the first radiograph. And so the radiographer has repeated the scan, but only with the second half of the chest X-ray on a separate image. But even despite this limitation, the AI was able to offer a series of differentials for this chest X-ray. As you can see, it's highlighted 4 different things: focal airspace opacity, solitary lung nodule, solitary lung mass, and cavitating masses. So here you go. If we click on each of these different findings, you can also see what the AI thinks are each of these findings. So you can see it's highlighted the same area, but it hasn't quite been able to say what it is, but knows that there's something suspicious there that needs further investigation. So this has been really helpful, because you might look at it and think, actually, I can't see all 4 of those things. But if you know all 4 of those things are differentials for the same area, then that also, helps you in your interpretation. This patient did go on to have a CT, and you can see that the area that was flagged up was an actual cavitating mass, which turned out to be lung cancer. And there were also metastatic deposits on the CT, which you can't see on the chest X-ray, but the CT helped us better qualify that. Now, some of you may be saying, that's great, I see the turnaround times are improving, I can see what it's picking up, but how accurate is it? So, of the 14 different findings that we said we wanted the AI to flag up, we looked at how many of the total chest X-rays we had were they flagging up these findings. So within a 3-month time period, we had 5,500 chest X-rays, and the AI was flagging up about 10% of those chest X-rays as warranting immediate radiologist review. And of those, most of them were single pathologies, so maybe a single lung nodule or a bit of opacity, and in a quarter of the cases, just under, it may have offered a differential or found more than one thing. If you want to know the relative frequencies of that, it looked like focal airspace opacity was the most common finding, but it was picking up some of the other 14 findings as well. Now, if we consider all of these 14 as one finding, i.e. one finding of query lung cancer, let's look at the confusion matrix and find out the accuracy rates. So I'm sorry if this is a bit small, but you can see here that if we look at suspected lung cancer, and we're using the radiologist authorized report as our ground truth, we find that in the 4-month time period that we looked at, the AI flagged 578 chest X-rays as wanting review, and of those 578, 68 were actually thought to be proper cancers needing a CT for evaluation. So the sensitivity was slightly low, and the positive predictive value was low at 12%. But you might be saying, why are there so many false positives of 510? Are they even worth flagging up? And actually, they probably were, because if we look at suspected cancer along with other findings that might be worthy of follow-up, but not necessarily a CT, so things like maybe consolidation, but we need to know that that resolves itself, we find that actually the positive predictive value is much higher at 60%, so actually 60% of these things that are being flagged up do require either a CT or some form of follow-up chest X-ray to resolve that. However, we do recognize that perhaps some of those 14 findings may not necessarily be all contributing efficiently to our service, so that is something that we will need to pin down and look into in a more granular way going forwards. I mentioned we also wanted to know how staff felt about using the AI tool and what their perceptions were before and after AI was implemented. So concurrent to this, we're also doing a staff survey, and we looked at but staff opinions prior to the AI going live, and also within a couple of months of it going live. We want to do another survey at the end, but so far I can only report the first 2. There are many questions on this survey, and I don't want to go through all of them, but what I can tell you is that if you look at this bar chart, one of the questions we asked was, how comfortable would you be for an AI to look at your own chest X-ray if you were a patient in hospital? And if you look at the white bar for results of the first survey, you can see that most staff had no opinion. They were in the middle. They didn't know whether it was good or bad. However, that has shifted somewhat to being more strongly agreeing for AI to be used on themselves now that they can see how it's used, how it's being implemented. We also asked of the people who used the AI how they felt about using the AI. So 8 people did respond to this after AI went live, and most of them do enjoy using the tool. Most of them feel they are able to recognize the limitations of the tool rather than just blindly going along with what it says. So they use it to assist them, but they're not sort of being blindly led and just agreeing with whatever. And most of them feel that they're not becoming too reliant on it. They see it as something that can help them, but they don't feel like they are overly reliant on this, that they've lost their own clinical judgment. So overall, it looks like people do enjoy it. It has improved our turnaround times. But what I would say is that some of the free text comments we've had were quite interesting, and I think they're important for anyone who's going to implement AI in clinical practice, because it shows that although you can use the AI, there are so many things along the patient care pathway that still have to be thought about. For example, people don't know what's necessarily being flagged if they haven't been trained to use the AI tool, or it hasn't necessarily been implemented on certain workstations and others. Sometimes the radiographers feel like, yes, they're calling the radiologist, but it's over lunchtime, someone's not there, they don't know who to call, the patient doesn't want to wait in the waiting room. What happens then? Some also feel that, okay, now the radiologist says you do need a CT for the same day, but whose responsibility is that to follow that through, to make sure that happens, and to make sure that the patient gets seen? So there are a few different things that do also still need to be considered that are in addition to implementing AI. You can't just put it in, leave it alone, and then think it'll sort itself out. So these are still things that we're constantly trying to improve and update, and we work very closely with the AI company to help with this, and they've been great within the Epsom and St Heliers Trust in helping us make sure that our staff are listened to and any problems that arise are dealt with in a very timely manner. So in conclusion, we're only really 3 or 4 months into this. We hope to continue for 6 months and then do a much bigger, more detailed analysis of how we've looked at all of our chest X-rays and CTs. The results are still being regularly analyzed, and we're still collecting data, so do bear with us. We hope to come back and give you more information soon. We eventually would like to expand the use, not just for lung cancer findings, but for any acute chest X-ray findings, and increase the number of pathologies we're trying to pick up on the chest X-rays within the trust. The success of this implementation has spurred on the staff to want to do more AI projects, perhaps even looking at AI for other parts of this lung cancer pathway, such as how it could be implemented for CT, for nodule detection. And we also do want to try to find a way to create a business plan to fund this long term, as many people in the NHS do as well. So thank you so much for your time and attention. If you do have any further questions, please do let me know. And I'd also really like to thank all of the staff at both of the trusts and hospitals for helping with this project. Thanks a lot.